Good morning, Professor Nova. Your voice looks so bad. Your voice so bad. We can hear you right.
We can hear you.
We can hear you right. Your voice looks so bad. Stay back. Professor Nova, we can get you at all. We can get you. Yeah. It's not.
You sound like a chicken.
You sounded different.
What's wrong with the sound?
So horrible.
My computer is crazy some days.
Now we got you.
Much better.
Yeah.
Okay. Oh, crap. Okay. Try it again. All right. Now I'm good, right?
Yeah.
Okay. Well, there's your little laugh for the morning. My chipmunk voice. Everybody ready? I'm gonna knock this one out of the park, right? Kaboom, home run.
Can I get
Baseball.
the Zoom information?
What?
Get the Zoom information so I can log into my other device.
Yeah, hold on.
Thanks.
Okay, it's in the chat.
Thank you.
Download your exam, guys. There's quite a few that are not downloaded. Okay, everybody needs to download their exam. Get into Exam Soft, download your exam. I need your computer, your Zoom pointed at your computer and your workspace. That's why you need the alternate one. All right, good morning again. Was the exam okay? You feel confident? Ready to go now? We all got A's, so we got those grades up. Everything's good, right? Miss Novak can go back to sleeping at night. Yeah, okay, good. I'm glad to hear that. Just a reminder, you are on campus for lab this week. So those of you who have lab today need to be here by 12 or 1, I'm sorry, 1 o'clock. We get out of class at 12. You come be here around 1. All right, we're going to do medication administration, all kinds of good stuff today, this week. Okay. So lost a few people. All righty, we're going to work on chapter 35 today. Chapter 35 is about parental medication administration. And when I say parental, I'm not talking about my parents. I'm talking about anything that is not part of the oral PO GI tract type administration. So any injections, including IVs, is parental medication, okay? So the 3 types of injections we're talking about today are intradermal, subcutaneous, and intramuscular. All right. So, oh, I didn't put my chart out. Let me get my chart. There it is. All right. So if you start on page 673, you notice there are there's like 22 terms there that you really should know. Looking for something I posted last night. So you need to know these terms like bevel and bleb and gauge and gluteal and induration. These are all things you're going to need to know because they're very good words to put into test questions, right? So we want to make sure that you know them when you can, so you can answer the questions. We are not going into the actual administration of the exam or the injection, okay? We will talk a little bit about insulin. We're going to talk about sizes and what kind of needles you're going to pick and what kind of syringes you're going to use. That's what we're going to cover today. So, has anybody ever given anybody a shot? Never have to give a shot to anybody? Insulin, family members?
Yes.
Yes? Is it easy?
Yeah, I think so.
Good. So yes, one of the problems with shots and nursing students is that they get very nervous about giving them. And so you have to practice before you get comfortable giving an injection. Once you give the injection, a couple hundred times, it'll be okay. You'll walk in, hit them. But those first few are very, very difficult. So this is why we practice this before we get into clinical, so that when we get into clinical, we're not like, so Okay, so principles for parental injections, okay? Parental means not delivered by the gastrointestinal tract, and that includes your topical stuff. Anything that's not injected, okay? It requires the use of a syringe and needle or an IV catheter to introduce the medication. So we give this for many purposes. One being that the person cannot take anything PO, okay? That they can't take the medication by mouth. Another one is to hasten the action of the drug. We learned that the absorption and distribution of drugs is quicker through injections than it is through the oral route, right? Remember that from last week before? All right. If we need a continuous infusion of medication, we're going to do an IV. If any of the digested juices would counteract the effects of the medication, because sometimes when you take medicine and it goes into the stomach, that hydrochloric acid in your stomach just degrades it and it's not going to do any good. Or we want to make sure that the dose is accurate, because remember, when it goes through your GI tract, we don't know exactly how much is going to get absorbed. What's affecting the absorption in the GI tract?
Bacteria.
Bacteria, what else? Go back to 33 and find the answer. Affects absorption and distribution in the GI tract.
Is it gonna excrete?
Well, it's going to get excreted, yes, but what types of things affect absorption?
We have age.
The pH? Yes. Anything else? What about somebody who has slow motility, that their GI tract doesn't run as fast as it should? Is that going to affect absorption of the medication?
Yes.
People who have circulation issues and they don't have the whole bloodstream thing going on around their GI tract, that'll affect absorption too, right? So yes, there's many reasons why when we give a PO med, we expect it to be absorbed, but we don't know exactly how much of that med is going to be absorbed. And it's going to be different in each person. So parental injections or parental medications given by injection are much more specific. And you know that they got the dose because it's not going through that GI tract. All right. So we use various angles for these injections. But first we have to talk about safe, effective administration, okay? Remember, before you give any medicine, whether it's injected or oral or topical or transdermal or sublingual, you need to know why you're giving that med. You need to know why this person needs this med. You need to know what it is. You need to know what the side effects are. You need to know what we're looking for, what's the therapeutic action. That is part of your job. That is part of your standard of practice. You can't just give a pill and not know what it's going to do to your patient, okay? Same thing with an injection. Secondly, we need to check drug allergies, Because once we inject a medication, we can't get it back. Okay? If somebody takes the wrong pill, we could probably make them vomit and get rid of the pill fairly easily if we had to. But if we're injecting it, we can't get it back. It's gone. And if somebody was allergic to it, well then, yeah, you're going to have an allergic reaction. And that can be very serious. So you always have to check your drug allergies. We're going to use sterile needle and syringes. When we're talking about syringes, and this is a syringe, right? This is a 10 milliliter syringe, okay? We need to keep everything as sterile as possible that's going to affect the patient. So when we're talking about a syringe, the only place we can actually hold the syringe is on the barrel, all right? Because this part is going to go into the needle, which is sterile, okay? So we don't want to contaminate that. We can push the plunger from here, but we don't want to touch it in here because we're putting that inside the tube, right? Everything inside the tube, the tip and the needle need to remain sterile because we're putting it inside the body. Remember, we're going through the skin to do this, and the skin being your first barrier against infection, right? So if we do this with a contaminated needle or a contaminated syringe, we are just pushing bacteria right into the skin, right through the skin. So we have to be very careful. If you're going to pull up your medication in a different location and take it down the hall, you need to put a label on that syringe that gives the patient name, the drug, and the dose. Because, you know, once they're all full of something, they all look the same. Okay? So you need to make sure you label your syringes if you're carrying them from one place to another. If you have a patient who's frightened, or you have a child or an uncooperative adult, you need to get assistance. You need assistance because if they are thrashing around, or they're, you know, A, you could miss the wrong spot, or B, you're going to stick yourself. So get assistance, get somebody else to help you give that injection. We always have to rotate injection sites. People who take injected medications every day, like diabetics, people who are on heparin, you know, there's some medications, you know, vitamins and things like that, that people need to take every day or once a week. We can't keep hitting the same spot, because if we keep hitting the same spot, we're going to cause that fibrous tissue or the scar tissue to build up. And then the medication is not going to absorb correctly because there's scar tissue instead of regular tissue that it has to go through. So we always rotate our sites. And how do we know where they got the last shot?
It should be documented.
It should be documented. It should be in the MAR. I gave this injection at 9 a.m. and I gave it in the right upper arm. Okay. That means I'm not going to give it in the right arm. I'm going to give it in the left arm, right? So you need an injection site that's relatively free of hair and open areas and moles and rashes and freckles. Now, why do we worry about freckles? After you give an injection, what are you going to look for?
Any kind of discoloration or reaction.
Right, you're going to look for redness, drainage, anything like that. If you're putting it into a mole or a freckle, that's going to kind of hide that sign that we're looking for. So we want to give it in somewhere other than those places. Okay. The more vascular the tissue that we're putting it in, the quicker the medication is absorbed. So given the types of injections that we're doing, which one do you think would absorb the quickest? We have intradermal, subcutaneous, intramuscular, and intravenous. Which one's going to absorb the quickest?
Intravenous.
Intravenous, because we don't have to actually absorb. We're putting it directly into the bloodstream, right? Good job. So if you look at our routes for parental medication, intradermal route, and I'm going to share this screen. It's a little table I made last night. I will put it in your announcements also. Okay, so let me make this bigger. Okay, so your intradermal injections, all right. When we're talking about needle gauges, the higher the number, the finer the needle, the skinnier the needle, okay? So like a 29 gauge needle is like a piece of thread. A 20 gauge needle is like a tine on a dinner fork, okay? So the higher the number, the smaller the gauge, the smaller the needle, all right? And it's also important to know what size needle we're going to use, because if we use a needle that's not long enough to get to the tissue we were expecting to get to, then we've given that medication by the wrong route, and you could cause damage. So we're looking at needle sizes, we're looking at angles, we're looking at the max amount in an injection and their sites, all right? So. Okay. So for the intradermal site, intradermal is where we take a little bit of solution and put it right under the skin. So a TB test is an intradermal injection, all right? Somebody who's getting an allergy test, those are intradermal injections. We're just putting a little bit of fluid under the skin to see if there's a reaction, okay? So the one you're going to be using the most, I'm sure, is tuberculosis testing. Generally, we put that on the inner forearm, but anywhere you have skin, you can do an intradermal injection. We're going to use a 1 milliliter syringe, okay, because the max amount that you're going to put in any one spot is 1/10 of a milliliter in an intradermal injection. When we inject our fluid, we want to make sure when we have a needle, okay, there's like a slice across the edge of the needle where we have one that's longer than the other. We want the bevel to be up, okay, bevel up. Do I have a picture of that? Actually, they're doing it wrong in that picture. So we will find, I know there's another picture in here somewhere. So yeah, on page 676, you can see where they're talking about the bevel, okay, on that diagram. You see how it's cut at an angle on the end? We want that hole to be up, the longer part down, okay? So the bevel has to be up when you're doing an intradermal injection. We're going to use a very small needle, a 25 to 29 gauge needle, and it could be like 1/4 of an inch long. Doesn't have to be very long because it's only going right under the skin. We're barely going to get into the dermis, okay? Angle of insertion is 5 to 15 degrees. Okay, it's going to be a real shallow injection. You're not going to be stabbing, you're going to be sliding it under the skin. So 5 to 15 degrees. And when we do it, we want to form a bleb. A bleb is a little bump. It's like a mosquito bite. So if you get a TB test that's done right, you should have a little bump at the end. Okay. I see a lot of TB tests that never get a bump, but there should be a bump because you've done your bevel up, you're putting it right above the dermis and you're pushing up the epidermis, okay? So you should have a bleb, visible elevation of the epidermis. It kind of looks like a mosquito bite. So that is the information for intradermal, all right? So the second type of injection is the subcutaneous route. Now this is going to go below the dermis into the subcutaneous tissue or the adipose tissue. All right. So we're going to select the site that is anywhere that has fluffy fat in it. Abdomen, back of the arms, top of the thighs, buttocks, you know, anywhere where we can feel the fluffy fat, we're going to use as a subdural or a subcutaneous injection. Okay. So the ones you're going to do most often is the abdomen and the back of the arm. What kind of medications do we give through subcutaneous injections? Any ideas?
The questions again?
What kind of medication gets injected subdural, not subdural, subcutaneous?
I give a Lovenox shot, which is a blood thinner.
Yes, Lovenox is subcutaneous. So Lovenox, heparin, those are subcutaneous injections. Insulin is a subcutaneous injection. Some vaccines are subcutaneous, okay? So when you're doing a subcutaneous injection, the maximum amount you can give in a subcutaneous injection is 1 milliliter. Okay, so you're not going to be using a 3, 5, 10 milliliter syringe. You're going to use a 1 milliliter syringe. All right. And it's only a small amount of volume. I mean, it can be as small as 0.5 milliliters or 5/100ths of a milliliter. Well, you use a fine needle because we don't have to make it through muscle, right? We're just getting into the fatty part. 27 to 25 gauge, and it needs to be about 3/4 to half an inch to 3/4 of an inch long to get to the subcutaneous tissue. The absorption time on a subcutaneous is slower than an IM injection because there's not as many blood vessels in that area compared with a muscle. So we give those kind of medications that require slower absorption, like your insulin and your heparin and your Lovenox. And the last kind of route is intramuscular, IM, okay? IM is injected into the muscle layer. And you can see that figure A there is your IM injection. It's going straight down. It needs to be at a 90-degree angle. You need to use a bigger needle because we have to get through the epidermis, the dermis, the subcutaneous, and into the muscle, which is a little tougher. So our needle sizes is going to be 20 to 23 gauge. And they're going to be about 1 to 3 inches long, depending on your patient. This is where your clinical judgment comes into play. If you look at your patient and they weigh 89 pounds soaking wet, you're not going to use a 3-inch needle, right? There's not a whole lot of tissue between the skin and the muscle there. If you have somebody who is rather obtund, has a lot of adipose tissue, obese, and we need to get into the muscle, we're going to pick a larger needle, okay? So we can get through all that tissue to get to the muscle. If you don't get into the muscle with most of these medications, you're going to cause damage to the skin because this medication is meant to be delivered to the muscle and absorbed from the muscle. So if it leaks up into the subcutaneous, that's when your arm gets really sore and you get redness and swelling and all of that, okay? There are specific sites that we do IM injections. It can't just go into any muscle, okay? The most frequently used are the deltoid. Where's your deltoid at? Anybody know where your deltoid muscle is? Where's your deltoid?
Like shoulder right here.
Right, it's up here on your shoulder. It's right below your shoulder blade, okay? It's right here in the middle of your arm. That's your deltoid muscle. Okay, ventral gluteal. Gluteal means what?
Your
butt.
butt?
Yeah, gluteal is your butt, right? Your gluteus maximus. Okay, ventral means to the side. We used to, and those of you who are MAs probably remember, we used to use the upper outer quadrant to give an IM injection. We don't do that. We don't use that dorsal gluteus site anymore because the sciatic nerve runs right through it and the nerve was getting hit and causing nerve damage. So now we have moved it over to our hip area, and I'll show you how to find that in the ventral gluteal. Vastus lateralis, where is that? Any idea? That's the muscle that runs along your thigh, from the top of your thigh down towards the side, okay? And then the rectus femoris is the top of the thigh. So we have the shoulder, the hip, and 2 places on the thigh that we can inject an IM injection. We can inject up to 3 milliliters of fluid in all those sites except the deltoid. The deltoid cannot take more than 2 milliliters. So if you have an injection that is 3 milliliters, then you're not going to be using your deltoid. Okay, you're going to be using one of the bigger muscles to inject that into. Okay, I will put this slide up in your announcements at break, okay, so that you can see it. All right. So yes, you need to have a chart like this. Write it out yourself if you have to remember what size needles you're going to use and what angle you're going to do and what sites you're going to use. Okay. This is like 10 test questions right here. All right. You have to remember this. So. Okay. Get everybody back in here. So obviously, if we're going to do an injection, we need a syringe. All right. Syringes come in different sizes, right? You can have anything from a half a milliliter to a 60 milliliter syringe. Obviously, we're not going to use the 60 milliliter syringe for an injection, but they come that big, okay? And what we have, if you look at the picture on 676, you have the plunger, which we don't touch the inside. We have the barrel, which we can touch. We're going to measure our liquid at the flat part of the black stopper on the plunger. Not the point, the black part, the flat part. And then the tip is where the hub opening for the needle goes into. All right. And then we have the needle, which we need to keep sterile. Sometimes we have syringes that have a slip tip like this. Okay, you just slide the needle on. Other times we have what we call a Lura lock, which I don't have any. Do I have one here? No, that's an insulin syringe. It's amazing what I find on my desk these days. So I don't have a Lura lock. You'll see it in lab. But you have to twist the needle onto a Lura lock. And then each syringe is calibrated differently. So if you look at the pictures on 677, okay, the top 2 are insulin syringes. An insulin syringe usually has an orange cap, okay, and it is a 1 milliliter syringe, or it could be a half a milliliter syringe, but it is measured in units, not milliliters. So you can tell right there at the end it says units. And when you're using your insulin, you're going to see that U100 is 100 units per milliliter. So you always use an insulin syringe for insulin. If you look at the tuberculin syringe underneath that, that is a regular syringe. It's a 1 milliliter syringe measured in milliliters, and it can go to 1/100th of a milliliter. Your big numbers are tenths, and the little lines in between are 100ths. All right, so you can measure more accurately with a 1 milliliter syringe because you can round it out to the nearest 100th. And then the 3 milliliter syringe, each one of the intermediate marks is 1/10, and then the big numbers are a whole milliliter. Okay, so each type of syringe has its own scale, like this one, which I don't think you guys can see, but this one only has 5 lines between the big numbers, okay? So each one of those little lines is 0.2, not 0.1. All right, the 3 milliliter syringe they show you in your book, each one of those smaller lines is 0.1. So if you were going to draw up 0.6 of a medication, it would go right past the line past the 1/2 mark. Okay, you can see the different size needles here on figure 35-8. And you can see how they go from really wide. The one with the clear bevel base on it is a filter needle. We use a filter needle to pull up liquid. We never, ever, ever inject anybody with a filter needle, because the purpose of the filter needle is to screen out impurities in the fluid you're going to inject. Okay, so they're usually big, they're usually nasty looking, and you're going to get rid of the impurities that are in the fluid before you inject. Okay, and then we have, well, it's probably a 20, and you can see that each one is, they have different lengths. So the little one at the end, the little short one, looks like it's a 29 gauge 1/4 inch needle. We probably use that for intradermal injections. Okay, 1/2 inch is probably for your subcutaneous injections, and then the 2, 3 at the end are probably IM injections. Without knowing what gauge they are, I can't tell you for sure. You never, ever, 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 ever recap a dirty needle. You don't recap a dirty needle. If you've used that needle on a person, we're going to engage the safety and put it directly into the sharps container. If we are recapping a needle to get to the patient, the needle is clean, you're going to use the scoop method, where you scoop the needle up into the cap for the needle and then pull it down to secure it. Okay, you can recap clean needles, you cannot recap dirty needles. So how do we prepare to use these things? Okay, preparing the syringe for use. Okay, we already talked about how to handle it. If you drop the syringe, if any part of it becomes dirty, you throw it away. Okay, don't try and use it. You need to label the syringe, and you do not prepare medication in one syringe and then transfer it to another syringe, which I've seen people do with things like morphine, where they're going to mix the morphine with saline. They're taking the morphine out with one needle and sliding it into another syringe. That doesn't work. Always label your syringes. Parental solutions come in various forms. We can have ampules, which is a little glass container, and there are some on figure 35-11. Okay, little glass container. They can have anywhere from 1 milliliter to 5 milliliters of medication. They are a one-shot use. We're not going to use it and save it. We're going to one time. You're going to carefully break the tip off that ampule, but it's very, very sharp. It is actually glass. So we're going to take a unwrapped alcohol wipe, you know, the ones with the foil wrapper on them, and you're going to wrap it around there and then push it away from you so that we don't cut ourselves while we were doing this. And then you're going to draw medication up with a filter needle, okay, from an ampule, because there might be little tiny shards of glass in there. Okay. The vials that are there, we can see a very wide variety of vials. They come anywhere from 1 milliliter to 10 milliliters to 30 milliliters, I mean, to 50 milliliters. Vials are all different sizes. The thing that makes it a vial is the rubber stopper on the top. Okay, so vials can be multi-use, you can get multi-doses out of them. So whenever we open up a vial, we need to date and time it, because medication expires at different times. So like the regular insulin there, the insulin there with the orange top, that's good for 28 days once you open it. Some other medications are only good for 24 hours once you open it, like TB. If it's not refrigerated, it's only good for 24 hours. So you have to date and time it when you open it. We're going to clean the top of the of the vial with alcohol. You're going to do that for 15 to 30 seconds. Make sure we get all the germs off of it. Because once that cap's off, it's just sitting there, right? Before we take any medicine out of a vial, we need to put air into the vial. Okay, because if we don't put air into the vial, then we're going to create a vacuum. Does anybody know what happens when you pierce a vial with vacuum in it? Mount Vesuvius, all the liquid comes flying out. Okay, because the nature abhors a vacuum, right? And so it's going to move the liquid from the vacuum into the air. So always add air to the vial before you withdraw. So we've cleaned the top, we've added air. Then you're going to picture on page 681. You're going to turn it upside down and pull down on the plunger to get your medication. And you don't want to pull out more medication than you need. You want to be careful so that we don't have to put anything back into the vial. Okay. When you put the needle into the vial, into the rubber stopper, you don't want to go straight down the middle. You want to go off to the side a little bit at a slight angle, because we don't want to do what's called coring the top. All right, coring the top is a big circle in the middle, and then everything leaks out. And it's not sterile anymore because air is getting in there. Okay. Mixo vials, you can see those in the back on this page, page 679. So in the back row there's a vial with a white cap on it. That is a Mixo vial that we're going to push the stopper in to get the powder and the solute, or this powder and the solvent are separated until you're ready to use them. And then you push them together, and then we have to make sure we mix it well. We're gonna roll it between our hands to mix it up so that we have no more powder in the vial before we administer it. Okay. The reason that happens is some medication does not remain stable once it's mixed. So we don't want to mix it ahead of time and then it not be good by the time we get it to the patient. Buy some of those, those are cool. When we are administering medication, sometimes we have to give 2 injections. Okay. And if possible, we'd only like to do it in one big shot. Okay. If it's going to be less than 3 milliliters, you can do it in one shot. But you have to make sure the medications are compatible with each other. Medications that are not compatible precipitate out. So once you mix them together, it's going to get real cloudy and you're going to see all kinds of, crystals and things forming in the medicine. Just throw that away because there's no way you're going to use it. But if they are compatible, you can put them both in the same syringe and then you only have to give 1 injection. When we're reconstituting a medication, we're going to talk about this in math this week too. We have the solute, which is your solid material, okay? And we're going to mix the dilutant or the solvent into the solid material to make the medication, all right? And you have to follow directions because it'll tell you exactly how much solvent or dilutant to put into that powder in order to get the right concentration. Remember, we talked about concentration, and you need to have the concentration that's on the bottle so that when you do your math, you're right, okay? So you need to mix it according to the instructions. You have to be very careful with that, all right? So if you're mixing medications, and this is specifically the one they're talking about here is for insulin. Insulin is for blood glucose control. You have to be very careful. It's a high risk medication because if we give too much, we're going to drop their blood sugar too low. If we don't give enough, we're not going to take care of the blood glucose at the rate it's at. okay? Sometimes we have orders and the only two insulins you can mix are regular insulin and intermediate acting, or an NPH. Those are the only two you can mix. There's all kinds of different, there's rapid action, there's short acting, there's intermediate, there's long acting, there's all kinds of different insulins. The only two you can mix are regular and NPH. All right, NPH is the intermediate. The regular insulin is always clear. The intermediate insulin is cloudy because it's got a, it kind of precipitates out into a powder, but it also has a protein in the solvent that keeps it from absorbing all at once. Okay, so how do we mix insulin? First thing we need to do is we get our insulins out. We make sure we have the right drug, the right patient, the right route, the right time, okay, the right dose. All right, we have all our information in front of us. You are going to clean the tops off of both the insulins. Then into the longer acting insulin, which will be the cloudy or the NPH, you are going to inject the amount of air that you would withdraw from that NPH. Take your needle out. Pull up some more air, put it into the regular. The amount of insulin you're taking out, put the same amount of air into the clear one, or the regular insulin. Turn it upside down and pull it out. Just the amount of your regular insulin. Now you're going to take that out of the regular insulin, you're going to put it into the NPH or the cloudy insulin, turn it upside down and pull out your NPH. So when you're done, you're going to have the amount that is both the NPH and the regular added together. So if I'm using 6 units of regular and 10 units of NPH, when I'm done, I'm going to have 16 units of insulin in that syringe. Okay, so it's cloudy, clear, clear, cloudy. Air in the cloudy, air in the clear, draw the clear, draw the cloudy. I guarantee you there's a test question like that. Okay, so you have to memorize it. You put the air in the cloudy, put the air in the clear, draw up the clear and draw up the cloudy. The whole goal of that is to keep the needle that has the cloudy insulin in it from touching the regular insulin vial. All right, because we don't want to contaminate the regular insulin. Insulin is very expensive, guys. These vials are like $125 a piece. Yeah, so we don't want to mess them up. We don't want to have to throw them out. Okay, so yes, when you're mixing insulin that way, if you're mixing any other medication, there isn't a specific order that you need to do it in, but you do need to make sure that you are drawing up the correct amount. All right, take a 10-minute break, and then we will get into our nursing process, okay? Okay, guys, time to come on back. Turn your cameras on. Okay, Jessica, Mackenzie, Heather, Davina, Maninatu, Amanita. Honey has some company. There's Davina. Okay, so we live and breathe by the nursing process, right? And it is no different when we're administering injections. So what do we need to assess before we give an injection? On page 683.
The expiration date.
Right, we need to make sure that the med has not expired. What else?
You gotta make sure you mix the insulin right there on the suspension
Right, we
bag.
need to make sure we prepare it correctly. What do we need to know about our patient?
Check for allergies.
Allergies, number one, always check for allergies, right? You
Yeah.
can't get it back. What else do we need to know about this medicine?
The potential side effects, if I can say.
Right, we need to know what it's going to do to our patient. We need to know the side effects. We need to know the therapeutic response. We also need to know why they're on this medication. You have to use your knowledge of A&P and pharmacology and, you know, put all the pieces together. If you have a patient who all of a sudden has an order for IM in Rocephin, which is an antibiotic, but we have no infection, then there's no reason for that patient to be getting that medication, at least not obvious. You need to do a little more investigating. There are times where orders get written on the wrong chart. You have to be aware, you have to be alert all the time when you're passing medications, because it's probably the most dangerous thing you do as a nurse is passing medications, right? So we want to make sure that we know why the patient is on the medicine, what it's going to do to our patient, where are we going to inject it? Okay, so we got to look to see where they got it the last time. We have to prepare it correctly. Okay, so that's all part of your assessment process. In addition to assessing the patient, so if they're getting insulin, then we're going to check their blood glucose, right? If they have an infection, we're going to check for signs and symptoms of infection and temperature and things like that. So you're going to assess your patient, but you also have to assess the order and make sure it's correct. All right. So every medication you give should be connected to some kind of nursing diagnosis. If you're giving a cardiac med, there should be some kind of nursing diagnosis about tissue perfusion, okay, or fluid overload. If you're giving an antibiotic, there should be a nursing diagnosis about an infection. So you have to be able to put your assessment with your nursing diagnosis and your medication. This is how we think in the whole cycle, all right? And then after we've checked our nursing diagnosis, we're gonna plan. What do we want to happen? What are our expected outcomes when we're giving this medication?
We want for the therapeutic range to be effective
Right,
or the outcome to be good.
yes, we want our therapeutic outcomes to be positive, right?
Yeah.
We want them to be, we're not gonna stick them with this needle for no reason. So our outcome is going to be that the medication works. What else do you have to plan though when you're giving an injection? Do you have to plan anything else? You have to plan on what size syringe you're going to use. Do you have the right needle? Does the medication have to be reconstituted? Okay, that all also has to go into your plan. It's not your outcomes, but you have to have all those things together. So then we have our implementation. Okay. So we talked about intradermal injections, usually given for TB tests, okay, or allergy testing. Our tuberculin syringe is very small, very fine. What size syringe, what size needles do we use for an intradermal injection?
23, 22.
25 to 29.
25 to 29. Remember, the bigger the number, the smaller the needle. All right.
Oh,
And what length? What length? How long is that needle going to be? 3 inches? 1 inch?
Half inch.
Yeah, no more than a half an inch. And how much fluid are we going to inject?
Up to 0.1 milliliter.
3 millimeter.
No. 3 milliliter, it'd be a big, huge bubble on my arm.
Is it
1
0.1
ml.
0.1. 0.1.
Really?
1/10.
Oh, the scope.
Just a little drop we're going to inject intradermally, right? When you get a TB test, they don't put, 3 milliliters in there. It's just a little tiny drop, okay? So if we are doing a TB test, when do we check it to see if it's positive or not?
72 hours, 48 to 72 hours.
48 to 72 hours. And what are the signs that it is positive or negative?
Swollen and redness.
Swelling and redness. And what we're looking for is induration. So who can tell me what induration is? Page 686.
Quality of being hard.
Right. It's the quality of being hard. So not only swollen, it needs to be firm. Okay. Just a soft swelling is not a positive TB test, but if it's hard and big, then it is positive. Okay. So we're looking for a positive reaction. Is hard swelling at the site more than 5 millimeters in diameter? More than 5 millimeters, I'm sorry. So it's about the size of a dime, basically, or bigger. All right. Some people react to the TB test, but they're not actually reacting because they have TB. They're reacting, they have an allergy to whatever's in the test. Okay. So, but if it's hard and swollen and red and hot, then there's definitely a reaction there. Okay. And if your TB reacts, it does not necessarily mean you have TB. It means you have been exposed to TB, which I mean, you can get exposed to TB in the grocery store. You don't have to be very far from home. TB is everywhere these days. All right. If you have patients or patients who have grown up in outside of the United States in the country that has a lot of TB in it, because a lot of the world has TB pretty regularly, they will react positive, okay, because they've been exposed. And then those patients who have had the BCG vaccine against TB will also test positive. So you can't give them a TB test because we know that they're going to come positive. So they're going to have to get a chest x-ray or a T-spot or some other test.
Yeah, sure. I just did my chest X-ray because I took the vaccine.
You got the vaccine, yeah. A lot of you got the vaccine. So yes, we have to know where they're from, what's going on. Negative means that we have an induration of less than 5 millimeters. Okay. Positive is 5 millimeters or greater. Okay. Any questions about intradermal injections? Okay. Subcutaneous injections, what do we say those were for?
Insulin or heparin.
Insulin, heparin, yes. Okay. We want the medication to absorb more slowly so we have longer coverage type thing. We don't want all the insulin to hit at once. Okay. We give heparin specifically in the abdomen. All right, because doesn't have a whole lot of moving parts in your abdomen. All right, it's given in the abdomen. You can give insulin in the abdomen too, but the abdomen has the most steady absorption rate. Okay, but heparin is definitely an abdominal medication, and you need to change the sites. Okay, on page 688, you have a little diagram of all different sites you can use for a subcutaneous injection. Now, I personally have never used the shoulder blades, but apparently you can. I usually use the arms, the thighs, or the abdomen. But for heparin, we have to administer it in the abdomen below the costal margin, which is below your ribs, and above your pelvis. Okay, in that area there. If we give it in arms and legs, there's a lot of muscular movement and it's going to absorb differently. We don't want that. You have to rotate from one side to the other. Okay. We don't want to give a subsequent injection too close to each other because heparin will make the tissue bleed. Okay, that's its purpose. So we're not going to rub after we give a heparin injection. We're not going to rub the site. We may put pressure on it a little bit, but we are not going to rub it. You know, if it hurts, sometimes people like to rub things. No, don't rub it because that will cause tissue damage and bleeding. All right. So you can tell people who receive heparin, they'll have these little purple bruises all over their abdomen. Okay. If they're little purple bruises, it's not a big deal. If the whole abdomen is bruised, then you have an issue. All right. When you're giving heparin, the lab test, who knows what the lab test is for heparin? Anybody hear of a APTT? Okay, an APTT is the test that measures the time it takes for your blood to clot. Okay, so it's measured in seconds. So if you're giving heparin, you better check your APTT to make sure it's not too high. And then we have our intramuscular injections. And remember, what are the sites we talked about for intramuscular injections? It wasn't that long ago, guys.
Ventral gluteal.
Ventral gluteal, that's one of them. What's another one?
The deltoid.
Deltoid. Two more.
the rectus femoris, and the vagus lateralis.
Right. 4 sites that we use, okay? An improper site selection can result in damaged nerves, abscesses, necrosis, sloughing of the skin, and pain. So we have to be careful which site we select and that we do it correctly, okay? And remember, when we're doing intramuscular injections, the needle has to be long enough to get into the muscle. All right, so the most common one you're going to see is the mid-deltoid. So you're going to, I can't do it on myself. Okay, you're going to put your fingers on your acromial process, which is your shoulder right here at the edge of your shoulder. You're going to go down 3 fingers, all right? And you're going to inject before the 4th finger. So you're going, there's a triangle about this big on your deltoid that you can hit. And it's basically, you want to be up as high as you can get into that muscle. All right. I've also seen people do this. You put your finger on the acromial process and then make a C and then inject in the middle of the C. All right. It's important you get into the muscle. Okay. So that's your deltoid. When we're talking about your ventral gluteal, okay, this is ventral gluteal is the preferred IM injection site. Okay. It involves the gluteus medius and minimum muscles. So it's a big muscle. It's a great site, but you have to find it correctly. All right. You're going to put the palm of your hand on your greater trochanter. Where is your greater trochanter?
Top of your hip.
It's the top of your hip. It's at the angle where the bone, the femur goes up and then turns to go into the hip socket. This here would be your greater trochanter, okay? So you need to make sure that we have our palm on the greater trochanter. You're going to reach for the anterior pelvis, and then you're going to inject between these 2 fingers. So there's a diagram on page 693, and you guys will be practicing on each other at some point in lab, okay? So we want to put our hand there, spread your fingers and inject. You want to make sure it's on the side, not on the back, because we don't want to hit the sciatic nerve. So, and what angle do we do an IM injection at?
90 degrees.
90 degrees, straight up and down, okay? And the other thing about IM injections is that we can do it as a Z-track. And you can see the picture of that on page 695. A Z-track is done in order to seal the medication in the muscle and keep it from tracking up the needle track up into the subcutaneous tissue, all right? So we have some medications that'll stain the skin. We have some medications that will destroy the subcutaneous tissue, all right? So we want to change the track. And you can see how the finger is pulling that skin back before they inject it. They inject it at 90 degrees, all right, into the muscle. And then when they let go, you see the white track on the second picture is not directly over the injection site. That keeps the liquid from tracking back up into that subcutaneous tissue. So there are really irritating medications, Phenergan, vitamin K. Those are ones that you have to do a Z-track. And that's all part of what you're going to learn and what you're going to look up when you're going to give an injection. How do I give this? Can I give it a regular or can I give it a Z-track? Okay. So your vastus lateralis muscle, and you can do this with all IM injections, can be a Z-track, okay? So it's going to be between the upper knee, the upper part of the knee and the groin, all right? So if you put your hand on your knee, right above your knee, you're going to inject right above your hand, okay? And it's off to the side, it's not directly on top. So you can see that on page 694. Okay, it's the muscle that goes between your patella and your greater trochanter, and it is on the side. Your rectus femoral will be right on the top of your, it's a smaller muscle, the rectus femoris. Okay, it's not very wide. Your vastus lateralis is a bit easier to hit. Okay. When you're injecting in children, we do not want to use the deltoid because they don't have the muscle development there. Okay, so when we so we want to give our medications over 13 months. You can use the deltoid site unless the muscle's poorly developed, but before that you want to use the vastus lateralis or the ventral gluteal. Okay, because the infants are moving their legs all the time. They have better muscle development in their legs than they do in their arms. Ways to decrease injection discomfort. You can put some lidocaine or EMLA cream on to decrease the injection discomfort. You can actually just put a little bit of pressure on the site before you inject, like when you're cleaning it with the alcohol pad, and then put a little pressure on the site. That's going to numb it a little bit and it's not going to hurt as much. Make sure your patient is calm and relaxed. If they're all tensed up and you hit that muscle, it's going to hurt more than if they just relax and let their arm hang. Then it won't hurt as bad. Okay. When you put your needle in smoothly, you want to dart it in. Don't push it through. You want to dart the needle in. That'll be a much easier insertion than pushing the needle through the tissue. That will hurt more. Okay, and then after you take the needle out, if you put a little bit of pressure on the site, that'll decrease the pain too. And then you want them to move around after an IM injection. Anaphylactic shock. What is anaphylactic shock?
When you stop breathing.
It's when you stop breathing. Well, that's the end result of anaphylactic shock, but yes. Okay. Anaphylactic shock is basically circulatory failure from allergic reaction. So we may have urticaria, which are large welts. You may see some bronchial constriction. They may have trouble breathing. You may see some edema in their face or around the area. And eventually it will lead to circulatory collapse where all your blood vessels just open up and all the blood flows out of your heart. Okay. So whenever we're giving an injection, we need to be careful that we make sure we keep an eye on this patient for a little while to make sure they're not going into anaphylactic shock. Okay. When my husband got his COVID shot, he had to sit for 15 minutes before he left in order to make sure he wasn't going to have a reaction to that first shot. Okay. So you need to, have equipment on hand. You should have oxygen, stuff for CPR, those kind of things when you're giving injections, which is something you need to think about when, you get a job giving COVID shots over at CVS. Okay. Where's the emergency equipment? All right. So always watch for allergic reaction. And then finally, we have to evaluate. Okay, we've assessed, we've planned, we have our nursing diagnoses, we've done our intervention, we're going to evaluate. And what are we going to evaluate?
How they react after giving the drug.
Right. Did we get the response we were looking for? Did we meet our goal? Okay. We're going to make sure, like if you gave a medication for pain, you want to make sure that their pain is gone. Okay. If we gave an medication for blood glucose, we want to make sure it went down. So we have to evaluate the therapeutic action of that medication. Okay. I'm going to let you guys go because you have to be here by 1 o'clock. Be safe, be careful. Remember, you need to be in complete uniform. If you need uniform parts, if your pants don't fit, your shirt doesn't fit, you need to get your uniform exchanged. You need to come in early. The bookstore will be available between 12:30 and 1 o'clock for you guys to exchange uniforms, pick up uniforms, whatever. Okay. Make sure that you're here like 1:45 otherwise, so that we can get you all upstairs and working by 1 o'clock. Cut your nails down, pull your hair back. Make sure you have white shoes, okay? Let's look really professional when we walk in, all right? Any questions? No? All right, guys, I'm gonna let you go. See some of you at 1, all right? See the rest of you on Thursday, okay? Have a good day.
Will I be on campus
Thursday is on campus, yes.
today?
All labs this week are on campus,
busy.
okay? I'll see you guys soon.